is Dr. Karthikeya. I am assistant professor from Department of General Medicine. I have 6 publications and 4 monograms in various index journals. I am also an API member. Today my topic is on gingival hyperplasia and stomatitis, and the learning objective of the class will be definition, clinical features, pathogenesis and management. Coming to the introduction, gingivitis refers to the inflammation of the gingival tissues surrounding teeth without loss of connective tissue attachment. It represents the earliest reversible stage of periodontal disease. Stomatitis denotes diffuse inflammation of oral mucosa involving cheeks, lips, tongue, palate or the gingiva. It can occur from infections, autoimmune or iatrogenic causes. Both conditions reflect oral mucosal responses to local and systemic insults, providing early clues to the underlying diseases. In systemic practice, these lesions may indicate hematologic, nutritional or immunologic disorders. Physicians must recognize these oral manifestations as a part of comprehensive systemic evaluation. The oral cavity serves as a mirror for systemic inflammation, infection and metabolic dysregulation. So, as you can see in this image, this is an image of gingival hyperplasia, both upper and lower part. Coming to the anatomy and normal oral defensive mechanism, the gingiva, which is a part of periodontium, consists of epithelial and connective tissue, providing a protective barrier around the teeth. Saliva maintains mucosal integrity through lysozymes, immunoglobulin A, lactoferrin and peroxidases that suppresses bacterial colonization. Resident microbiota form a stable biofilm that completely inhibits pathogenic species. Mechanical cleansing via mastication, tongue movements help in removing debris and microorganisms. Epithelial turnover ensures rapid shedding of infected or damaged cells, maintaining mucosal health. Systemic conditions like xerostomia, diabetes or malnutrition impair these defenses and predispose to oral inflammation. Now coming to the pathogenesis of plaque induced gingivitis. Dental plaque biofilm initiates inflammation through microbial toxins and metabolic byproducts. There are some gram-negative anaerobes like Porphyromonas gingivalis, Fusobacterium nucleatum, which trigger the immune activation. Polymorphonuclear leukocytes infiltrate these junctional epithelium, which releases some cytokines like interleukin 1 beta, TNF alpha and matrix metalloproteinases. Vasodilation and increased vascular permeability produce erythema, edema and bleeding tendency. Chronic exposure leads to predominance of plasma cells and lymphocytes, sustaining low grade inflammation. The condition remains reversible if the plaque is controlled before connective tissue destruction begins. So, coming to the classification of gingivitis, we have plaque induced gingivitis, non-plaque induced gingivitis, drug induced gingival enlargement, hormone related gingivitis, nutrition deficiency like vitamin C deficiency, which can cause bleeding gums and which we have seen very commonly in our day to day clinical practice. Systemic diseases associated gingivitis may accompany leukemia, HIV or granulomatous diseases. Coming to systemic association of gingivitis, one of the most common disease which can affect this problem is diabetes mellitus, which we see every day. Okay, so that causes exacerbation of gingival inflammation through impaired neutrophil function and glycation related microangiopathy. Some leukemias can manifest as diffuse gingival enlargement with spontaneous bleeding due to leukemic infiltration. HIV again, which can predispose to linear gingival erythema and necrotizing ulcerative gingivitis. Scurvy, vitamin C, which I already told you, which weakens the collagen and causing ulcerative or friable gums. Pregnancy gingivitis again, which can arise from hormonal vascular engorgement and increased prostaglandins. There are some medicines which can cause gingival hyperplasia. Commonly used drugs are phenytoin, cyclosporin and nifedipine. So, this is an image of vitamin C deficiency, that is scurvy, shows bleeding gums, and some images I have attached depicting gingival hyperplasia with use of medications like phenytoin, nifedipine. Coming to the clinical features of gingivitis, Uh, so, the clinical features will be erythematous, swollen gingiva with loss of stippling is an early hallmark. Bleeding on gentle probing reflects capillary fragility due to inflammation. Halitosis, which is foul odor, arises from volatile sulfur compounds produced by anaerobes. Patients may complain of tenderness or gum discomfort, especially while brushing or chewing. No radiographic bone loss is present that distinguishes gingivitis from periodontitis. In chronic forms, color changes, fibrotic thickening or spontaneous bleeding may develop. Now coming to the stomatitis topic, introduction. Stomatitis refers to the inflammation of oral mucosa resulting from infections, irritants or systemic diseases. It can be acute or chronic, localized or diffuse, involving any part of the mucosal surface. Common types are aphthous, herpetic, candidial, necrotizing and allergic stomatitis. Pathogenesis involves direct mucosal injury or immune mediated epithelial destruction. Pain, erythema, edema and ulceration are the typical manifestations. Physicians must consider nutritional, hematologic and immunologic causes in recurrent or atypical presentations. Classification: we have infectious stomatitis, aphthous stomatitis, allergic contact stomatitis, radiation or chemotherapy induced stomatitis, nutritional stomatitis which is again due to vitamin B complex, iron or folate deficiency, and autoimmune stomatitis like Behcet syndrome, pemphigus vulgaris or lichen planus. Pathogenesis of stomatitis: epithelial injury initiates inflammatory cascades releasing cytokines like interleukin 6, TNF alpha and prostaglandins. Viral infections, particularly HSV1, causes cytopathic effects with vesicle formation and mucosal ulceration. Fungal infections, especially candida, can exploit immune compromise or antibiotic induced flora disruption. Autoimmune forms involve autoantibodies against desmosomal proteins leading to epithelial acantholysis. Nutritional deficiencies impair epithelial regeneration and local immune defense. Drug induced stomatitis involve direct cytotoxicity and microvascular injury, which we see every day. Okay. So, now coming to the images, can you see the angle of the mouth here? We have some lesions and even in the posterior pharyngeal wall. So, these are the images for the stomatitis. Coming to the clinical features of stomatitis, painful oral ulcerations are the most frequent symptoms. Erythema and edema of the mucosa can represent acute inflammatory response. Vesicles or bullae can appear in viral or autoimmune forms. Candidal stomatitis present as white curd like plaques which can be wiped off and you can see bleeding underneath. Necrotizing forms show pseudomembranous and halitosis, especially in immunocompromised or malnourished patients. Chronic cases may show atrophy, fissuring and secondary bacterial infection complicating healing. Coming to the differential diagnosis of oral ulcers, which are aphthous ulcers, herpetic ulcers, traumatic ulcers, TB or syphilitic ulcers, malignant ulcers and autoimmune mucocutaneous disorders. Coming to the complications of stomatitis and gingivitis, untreated gingivitis may progress to periodontitis leading to loss of attachment, bone resorption and tooth mobility. Chronic oral inflammation is linked to systemic inflammatory burden contributing to atherosclerosis and endothelial dysfunction. Bacteremia from oral infections can cause infective endocarditis in predisposed individuals. Severe stomatitis can result from malnutrition and dehydration due to painful oral intake. Opportunistic infections like oral candidiasis can herald from immunocompromised state like HIV. Persistent lesions may undergo malignant transformation. Coming to the diagnostic approach and management, a comprehensive oral examination, history taking with respect to oral hygiene, medication use, dietary habits and systemic illnesses. CBC may reveal leukopenia, anemia and thrombocytopenia. Blood glucose and HbA1c helps to identify uncontrolled diabetes mellitus, which can be a contributing factor. HIV and hepatitis B or C virus testing are indicated in chronic, atypical or ulcerative lesions. Microbiologic cultures or biopsy can confirm in resistant or suspicious cases. Coming to the lab and imaging evaluation, Gram stain and culture can identify bacteria pathogens like Streptococcus or Fusobacterium. Fungal culture or KOH mount confirms Candida species. Zhang smear or PCR analysis helps diagnose herpetic stomatitis. Biopsy with histopathology reveal acantholysis, dyskeratosis or lymphocytic infiltration suppressing autoimmune etiologies. Radiographs or panoramic imaging may show alveolar bone integrity, differentiating gingivitis from periodontitis. Nutritional assays like checking for vitamin B12, folate and iron levels may be useful when deficiency states are suspected. Management includes plaque control through meticulous oral hygiene and professional scaling. Antiseptic mouth washes are available like chlorhexidine 0.12 to 0.2%, which can reduce the microbial load. Topical anti-inflammatory agents like benzidamine NSAID mouthwashes also can be used for pain control. Discontinuation or substitution of offending drugs needs to be enhanced. Correction of systemic factors including blood sugar control in diabetes enhances treatment efficiency. Follow-up dental evaluation ensures resolution and prevents recurrence. Management principles are identify and eliminate the underlying cause. I already told you about topical anesthetic agents and coating agents which are lidocaine and sucralfate, which can relieve pain and protect mucosa. Antiseptic and antifungal again like chlorhexidine, nystatin can be used to suppress the organism growth. Systemic antivirals like acyclovir can be tried in herpetic stomatitis with fluconazole, which treats extensive candidiasis. Vitamin supplements like B complex, folate and iron is vital in deficiency related forms. Severe cases may require systemic corticosteroids or immunosuppressants under specialist supervision. To summarize, gingivitis is a reversible inflammation confined to gingiva, while stomatitis represents widespread mucosal inflammation often linked to systemic diseases. Microbial biofilm, immune dysfunction and systemic comorbidities form the central triad in pathogenesis. Early recognition of oral lesions offers a valuable window to diagnose nutritional, hematologic and immunologic disorders. Comprehensive management integrates local therapy, systemic optimization and patient education. Regular oral hygiene and interdisciplinary collaboration between physician and dental professionals are essential to prevent progression to periodontitis. Recent advances in molecular diagnostics, probiotics and laser therapy are reshaping preventive oral medicine. The physician's awareness of oral manifestation of systemic diseases significantly improves holistic patient care. And these are my references of the images. Thank you everyone.